Okay, we are live now. We can go ahead.
So, very good morning, esteemed panel members and delegates for today's webinar. You all are aware that the world is changing at quite a very high pace because of the changes in science and technology. And yes, because of this, a lot many things which were used to be done very conventional through very conventional processes in years back. Nowadays, we have the things absolutely changed over the time, and all things are being conducted in a very different way. And the same thing applies, yes, to medicine as well. Even in medical field or in medical aspects, we know that yes, things have changed and they have moved from at a very high pace. And I would say that things which or the ways of managing the diseases which were there just some 5 or 10 years back, they are just obsolete now. And we have a lot many newer guidelines and newer ways of managing the things. We have newer, I would say, recommendations, newer molecules coming up. So yes, if we want to really manage the patients in the best way, we need to keep ourselves updated. This has been published that every physician has at least 3 to 5 clinical questions that remain unanswered on every day while managing the patients. So if we want to really find answers to this, when we just look into newer molecules, newer guidelines and everything, so we have a lot many questions. There will be who, what, where, how, when, why. So multiple W's are pondering upon us every day. So to find these answers, yes, we need some good people or some people who are really experts in the field who can guide us to understand how the things to be managed. So to answer all these W's, we hereby invite all of you to this today's wonderful webinar, which is being conducted under the aegis of Fragility Fracture Network India. This webinar today is under the Aware series, under the IFFN webinar series. And for this webinar, I really feel delighted that we got an opportunity to, means Entas has got an opportunity to partner with FFN to come up with this wonderful webinar. To introduce all the panel members, I would like to invite Mr. Javed Sharif, who is head of sales in Entas. Over to you, Mr. Javed.
Very good morning, respected panelists and esteemed speakers for today's wonderful webinar. Dr. Malhotra sir, Dr. Venkateshan sir, and Dr. Bhavukar sir. Medical affairs team from Intas, Dr. Amit Jain. I am joined by our marketing team, Mr. Chandraketu, Dr. Vinish Garg, as well as Ms. Anjali. A warm good afternoon to all of you. It's indeed a privilege and pleasure to host such a wonderful webinar, which today is being done under the aegis of Fragility Fracture Network Aware series. All W's are answered. Dr. Rajesh Malhotra sir has been a pioneer of Fragility Fracture Network in India, and it is my pleasure to introduce him. Though he does not require much introduction, he is a very well-known and eminent academic personality among not only orthopedics but entire healthcare community in India. Currently, he is a professor and head of orthopedics at All India Institute of Medical Sciences, New Delhi, chief of JPN Apex Trauma Center, AIMS, New Delhi, associated with establishment and in charge of the only cadaveric bone bank in India at AIMS. He's been the past president of Indian Orthopedic Association and recipient of the prestigious BC Roy Awardee. And I wouldn't have much words to probably thank him to accepting our invitation to be a speaker for this wonderful webinar. And his expertise will help us to clear many W's related around Denosumab in osteoporosis. With this few words of welcome, I would like to invite Dr. Rajesh Malhotra sir to deliver his talk on Denosumab in osteoporosis. Dr. Rajesh Malhotra sir.
Thank you, Javed. And good afternoon, everyone. It's a pleasure to be here, and I'm going to actually talk about the use of Denosumab in osteoporosis. And we at the Indian Fragility Fracture Network have been conducting such aware programs, and recently we had a slogan competition in Hindi and English, and this morning we distributed the prizes to the winners of the first prize, second prize, third prize in each category of Hindi and English, as well as the consolation prizes. So I think the idea here is that all of us must be cognizant of the seriousness of the fragility fractures, and it has to be an activity from everyone. Now, uh, in the same spirit, I would like to talk about the newer treatments available for osteoporosis. The fact that we still don't have a perfect treatment for osteoporosis is evidenced by the fact that we keep on having new molecules, and then we are looking for the additional benefit or advantages of the newer molecules, which can take care of the deficiencies or the drawbacks of the previous treatments available. Now, we know that the bone strength is compromised in osteoporosis with increased risk of fracture, and it affects the bone density as well as quality. So bone strength is actually a function of bone quality and bone mineral density, which you can express as areal, which is as gram per centimeter square, or volumetric in gram per cubic centimeter. So the bone quality, by that we mean the microarchitecture, the geometry, the size of and thickness of trabeculae, their interconnectedness, the turnover or modeling rate, damage accumulation, degree of mineralization, and the properties of the collagen and the mineral matrix. So in osteoporosis, we have reduced bone mass, we have decreased trabecular thickness, we have decreased number, decreased horizontal struts, which are actually the very strength providing structures, and the reduced connectivity. And then we have some plates which undergo perforations. So this is the normal bone, this is moderate osteoporosis, and from there it goes to the severe osteoporosis. When it comes to treatment, our aim is to have primary prevention, because we know that once there is a fracture, there is a cascade or a domino effect, and one fracture keeps on begetting other fractures. We have to stabilize or increase the bone mass. We have to relieve symptoms of fractures and or skeletal deformities, and improve mobility and functional status of the patient. Now, we all know that the bone is not static. It's highly dynamic, and that's how it's able to provide calcium for various physiological functions by removing calcium from there, and it keeps on depositing and removing calcium. It is actually constantly repairing the damage which is occurring in the bone by a cycle which is called bone remodeling cycle. So normally the rate of resorption equals the rate of bone formation, and there is no net bone loss. However, at menopause or under the influence of glucocorticoid or other factors, there can be impaired bone remodeling where the resorption rate exceeds the formation rate, leading to a net bone loss. So this is actually a classical trabeculae. The osteoclast will come and remove the bone, and that will take just a few days, whereas the osteoblast will take more than 3 to 4 weeks to fill up this defect. So when there's a mismatch between the bone resorption and bone absorption, that leads to a lot of areas of or pits in the bone, which will then become weak points for fracture. And therefore, the therapeutic options essentially concentrate on either inhibiting the bone resorption, which is actually the major strategy, or the stimulating the bone formation. We really have only one agent here out of that, which is the parathyroid hormone, but we should have more coming in. So, and out of these inhibitors, the bisphosphonates are the workhorse. So let's talk about the anti-osteoclastic factors. So out of them, primarily, if you look at the hormone replacement therapy, it's actually got the additional advantage of relieving the postmenopausal symptoms. It prevents bone loss and fractures, increases bone mineral density, decreases bone turnover, and it's actually slightly reduces the risk for vertebral fracture, though it's not very effective in preventing osteoporotic fractures. But then the biggest problem is the risk of breast cancer, leg cramps, and the DVT and stroke, which make it a difficult agent and is not currently recommended, except for the relief of most menopausal symptoms. Calcitonin has actually more or less gone out of favor because although it was claimed that it increases BMD and decreases fracture, it hasn't been shown to be much effective. And at present, it's only an expensive analgesic for relieving pain, particularly in the osteoporotic vertebral fracture. The selective estrogen receptor modulators have been tried. They are very weak agents. They have specifically not much of a protective effect on hip fractures. They can actually aggravate menopausal symptoms. So you have to give them 2 years after that, after the menopause, and they still have a risk of swelling, deep vein thrombosis. So bisphosphonates, particularly the oral one, remain the workhorse because they are easy to administer. They are easily available and cheap and affordable, but they are very difficult to actually comply with. They can be taken only early in the morning when the patient has to be upright for 40 minutes or 30 to 40 minutes after taking it, and they should not take any thing other than water, because then the bioavailability goes down, and then basically it leads to factors like esophagitis, GI side effect, which also, if you have any of the esophageal symptoms, that almost rules you out as a candidate for oral bisphosphonate therapy. Moreover, the long term may use to atypical femoral fractures or the osteonecrosis of the jaw. And then, although they are believed to be one of the most effective, we should take a relook whether it's effective enough. So, like I said, the oral bisphosphonates are contraindicated in esophageal disorders. And if the patient cannot be compliant about staying upright for at least 30 minutes after certain types of bariatric surgery. And then when it comes to the IV bisphosphonates, the patients with chronic kidney disease with reduced eGFR or creatinine clearance are not candidates for this. Teriparatide has a problem of compliance and cost. It's the only anabolic therapy available in India. It needs daily subcutaneous injections, which may reduce the compliance. At critical sites, its effect on trabecular bone is very good. In fact, teriparatide and bisphosphonates are opposite when it comes to mechanism of action. The bisphosphonates suppress bone remodeling, so they reduce the bone resorption as well as bone formation, whereas teriparatide increases bone remodeling. So it increases the bone resorption as well as the bone formation. So the effect of the teriparatide on cortical bone is variable, but by virtue of increasing the diameter of the bone, it is able to give some protection against the diaphyseal fractures. The vitamin D deficiency and hyperparathyroidism is mentioned here because the osteoporotic patients are often have vitamin D deficiency, and you can understand that if you have hyperparathyroidism, you cannot be treated with parathyroid injection. So that is something I want to tell everyone. Before you ever start parathyroid hormone treatment, you must measure the calcium phosphate, alkaline phosphatase, 25-hydroxy vitamin D and PTH levels in the blood, so that you don't end up aggravating the pre-existing hyperparathyroidism due to osteomalacia. So even primary hyperparathyroidism is relatively common in elderly people, but you can have a secondary one due to underlying due to an underlying cause, and that hypercalcemia should not be missed, and you should not treat it with teriparatide. Moreover, it has a limited duration of therapy, like you cannot give it for more than 2 years, and there is a constraint. What do you do when you have to give it for more than 2 years? Because we know that there's a black box warning that the teriparatide should not be given for more than 2 years because of the risk of osteosarcoma, which was seen in the rats. The special populations again are deprived of this mode of treatment, because the renal patients, the teriparatide excess lasts much longer. It's not advisable. And in cancer patients who already have cancers, it is advisable not to use it because of, like I said, that the risk of osteosarcoma, which was seen in rats. So we have a gap in therapy. When we talk about antiresorptives, we have inadequate response, compliance issues, GI problem, and other adverse effects. On the other hand, when we talk about anabolics, we can use it only for a limited period. Not all patients qualify for it. The hyperparathyroidism has to be looked at. Renal compromise and cancer patients cannot be given this benefit. So we have to find the balance in efficacy, safety, compliance, and cost. And possibly this is one new agent which can help us through this. So it's a fully human monoclonal antibody, IgG2 isotype, which has high affinity and specificity for human rank ligand, and it's an anti-resorptive agent. So essentially it is anti-resorptive, but the mechanism is different from that of the bisphosphonate. So this is how the the postmenopausal osteoporosis works to rank ligand. So basically, rank ligand is essential for the attachment of the rank, which causes conversion of the precursor cell to the activated osteoclast as compared to the osteoprotein, which leads to the formation of the cell into osteoblast. So when in this upregulation of rank during postmenopausal times, and that time more of these are converted to osteoclast, so there is an upregulation and there's increased osteoclastic activity. And what denosumab does is actually it diverts more of these cells towards the osteoblast side, because it inhibits the osteoclast formation, function, and survival. So they are actually diverted more towards the osteoblast, and it inhibits the osteoclastic resorption. So the approved indication are, first is the postmenopausal osteoporosis, which was given out more than a decade back. And then it was subsequently a few months later, it was approved for the skeletal related events in patients with bone metastasis and solid tumors. Then it was subsequently approved for adults and skeletally mature adolescents with giant cell tumor of the bone. And then in May 2018, it was approved for glucocorticoid-induced osteoporosis. And you'll hear more about these from my colleagues. And in India, it is approved for postmenopausal fracture, postmenopausal osteoporosis with high risk of fracture, and for men with osteoporosis to increase bone mass. So the dose is 60 milligram every 6 months as a subcutaneous injection, which can be given in the upper arm, upper thigh, or abdomen. Patients have to take the universal treatment of calcium and vitamin D every day. The contraindications are hypocalcemia, pregnancy, and known hypersensitivity. The serious adverse effects in large series have been reported in a small percentage and include infection, cellulitis, malignancies, osteonecrosis of jaw, and atypical fracture. The upper ones are often seen with other monoclonal antibodies, whereas the lower ones are basically common to any anti-resorptive treatment. So the largest study done for denosumab is the FREEDOM study, which enrolled nearly 8,000 patients who were randomized to receive either denosumab or the placebo. And what was the endpoint was primarily to see new vertebral fracture, and the secondary was non-vertebral and hip fracture. And you can see the relative risk reduction: 68% reduction in the new vertebral fracture, 20% in the non-vertebral, and 40% the hip. So what strikes you here is, we know there are agents which act separately on vertebral and non-vertebral fractures, or the or the hip fracture, or the we always look at the effect on the vertebral fracture, hip fracture, and non-vertebral non-hip fracture, and you can see a significant reduction there. So 68% reduction in vertebral fractures, 40% in hip, and 20% in non-vertebral. And this is how the change in the BMD occurs. You can see the placebo here and the denosumab here. It's quite evident that 9.2% increase in bone mineral density at lumbar spine during this study, and 6% at the hip. So in the extension, in the extension, more patients were actually recruited. Long-term results were seen.
Sir, I think we have lost the connect with Dr. Rajesh Malhotra. We're not able to hear you.
I think, shall we wait for a while, a minute or something, so that sir reconnects?
Yeah, we should wait for him for a few minutes. Meanwhile, anybody has any questions, we can take.
If possible, sir, Bhavuk sir.
Sir is there.
Yes,
Hello?
sir, is there. Sir, you are muted. Sir, we lost you in between, sir.
Okay, so give me some idea where exactly you lost me.
So you were talking about the freedom extension study, and you
Freedom
can
extension
start with the same
study.
slide.
We haven't missed much, so just let me just get back there.
You'll also need to again reshare your slides, sir.
I will just reshare again.
Yes, sir. You were.
Yeah. So,
Yes.
So we were good here. We saw that the Denosumab group had 9.2% increase in bone mineral density at the lumbar spine and 6% at the total hip. Now, this study was extended, and 66% of the patients in the initial study completed the study in both the arms. And this is the data at 10-year data, which showed that there was a low rate of adverse events, low fracture incidence compared with that observed during original trial, and continued increase in BMD without plateau. So the BMD, which was increase, which was seen to be 9% in the initial study, went up to 21.7%, and the BMD at the hip, which was 6%, went on to 9.2%. And these graphs are self-explanatory, which show that there is no plateau. You can see at all the critical sites, the BMD continued to increase, and there was a significant change in the resorption markers, CTX1 and the TRAP. And you can see there was 63 to 88% reduction with the Denosumab here, and 40 to 50% reduction in TRAP 5B with the use of Denosumab. Now, the adverse effects are on the immune system, like I said, which is common to many monoclonal antibody therapies. And it can cause some infectious and neoplastic complications. So because the rank is expressed in cells other than osteoclast precursors, including the dendritic cells and T and B cells, so there may be some sort of interference with the immune system. So in the freedom trial, this is the summary of the adverse effects, which you can see that the all effects, which if you count, if you look at all the total effects, the number of fatal complications were 1.8% of all the adverse effects, and only 2.4% of the side effects led to study discontinuation. But majority of the side effects were in terms of infection. There was some cancer reported, which is obviously an adverse effect, and then basically the eczema, flatulence, and cellulitis. So again, I said cellulitis is seen with the therapies which involve the monoclonal antibodies. So and like I said, there are adverse effects related to the monoclonal antibodies, and there are adverse effects which are common to all the anti-resorptive therapies, which includes the osteonecrosis of jaw and the atypical femur fractures. So in freedom extension trial, there was 5 cases of osteonecrosis of jaw and 1 case of atypical femoral fracture after 8 years. And after 5-year crossover, there are 3 cases of osteonecrosis jaw and 1 case of atypical fracture. The biggest advantage, I think, which I consider, because many of these patients with severe osteoporosis are renal impaired. They are old, renal impaired, or have multiple diseases, and it is safe in renal impairment. There are very few osteoporotic medicines which can be given to patients with renal impairment. You don't need any dose adjustment in patients with stage 4 chronic kidney disease. So it has really, renal function has really no impact on the pharmacokinetics and pharmacodynamics. And if you look at the distribution of bisphosphonates are rapidly absorbed to the bone surface at the sites of bone turnover. That bone has got big avidity for it. So they act on the trabecular bone, because that's where most of the bone remodeling is taking place. But Denosumab circulates in the blood and extracellular fluid, so it can attach to both trabecular as well as the cortical bone. So effect is on both the sides. And second thing is, it increases BMD at all the critical sites. I mentioned that, when you talk about teriparatide, it has limited effect on cortical bone. It has limited effect on preventing hip fractures. although it's very effective against the spine and the radius. So denosumab is actually increases BMD at all the critical sites. And when you compare denosumab with the alendronate, which was done in the DECIDE study, you can see it's markedly more effective. It gives to a more rapid onset of action and a stronger inhibition of the bone turnover and bone turnover markers as compared to the bisphosphonates. So this is a history of this is a study of patients who were actually previously treated with oral bisphosphonates and with zoledronic acid compared to the gain which was obtained after starting treatment with denosumab. So if the patients were treated with oral bisphosphonates earlier, they were actually randomized to receive either denosumab or the zoledronic acid. And when you compare the two in patients with previous bisphosphonate therapy, you can see the effect is far stronger with denosumab here as compared to the zoledronic which is seen in red. So even if you have been on bisphosphonates, the subsequent administration of the denosumab has much more potent effect than the zoledronic acid, which is actually one of the strongest agents we have had till now. Similarly, this same study response at 12 months, you can see the difference between the two arms, denosumab versus the zoledronic acid. So significantly more bone mineral density, quicker thing, and in the femoral neck and distal radius, zoledronic failed to show any significant increase in the bone mineral density, which was seen only with the denosumab. Again, comparing the reduction in bone turnover markers, significantly more reduction here with the denosumab compared to the zoledronic acid. Therapy adherence was much more than alendronate in the DAP study. So when it comes to adherence, it is much better. And then there is some evidence in glucocorticoid-induced osteoporosis showing the BMD percentage change from baseline in patients who are treated with the denosumab, showing the comparison between the risedronate and denosumab, and showing that the denosumab is much more effective than risedronate in glucocorticoid-induced osteoporosis. And the improvement in T-score over 2 years, again, the denosumab suppressed bone metabolic turnover and increased T-scores in lumbar spine and femoral neck. A quick word about the Indian experience. There has been a study published in Indian Journal of Endocrinology Metabolism, double-blind, multi-center, phase 3 style, 250 Indian postmenopausal women with osteoporosis received randomized to receive either denosumab or placebo, and along with the standard supplementation. Look at the change in the BMD from the baseline with the denosumab seen in blue. Look at the change from baseline in the BMD, total hip, the femoral neck, as well as trochanter, as well as the reduction in the resorption markers or resorption of the bone, and quite a significant impact. So the study conclusion was that the results in Indian patients are comparable with those in the rest of the world, and denosumab was well tolerated and effective in increasing BMD and decreasing bone turnover markers over a 6-month period in Indian postmenopausal women. However, there are some counseling pearls. The drug must be kept in refrigerator prior to injection. Remove it only 15 to 30 minutes before injection. Patient must take supplemental calcium and vitamin D, and must remember that all the benefits are rapidly reversed when you discontinue the therapy. So what happens when you discontinue? If you discontinue after 2 years, the bone turnover rate is increased again after 3 months, and the BMD declines to the pre-treatment level within 2 years. So you have to keep going. There is also a certain increase in the rebound vertebral fracture incidence. So there have been studies which the reports of 9 cases of female patients having vertebral fractures after discontinuing denosumab, and 8 out of these 9 had numerous fractures. So it's like, giving the beta blockers You can't just stop one day and disappear, because then there's a rebound increase in the bone resorption and the fractures. So to summarize, Denosumab is the first human monoclonal antibody which inhibits the activity of rank ligand. As compared to bisphosphonate, it has superior efficacy, better safety profile, better compliance, and it improves BMD at all the critical sites. And as compared to teriparatide, it has a long-term safety. It is safe in hyperparathyroid patient, safe in compromised renal patient, and safe in cancer patient. Thank you very much for your attention.
Thank you very much, sir, for that wonderful, interesting, and informative talk on a role of denosumab in osteoporosis. I'm sure there are a lot of W's which you have already answered through your elaborate and wonderful presentation. And maybe question and answer session we will take it at the end, post the other speakers. And as you all are very much aware, role of denosumab is beyond osteoporosis. It has a role to play as far as in giant cell tumor also. To throw more highlight on the role of denosumab in giant cell tumor, it's my pleasure and privilege to invite our next speaker in this webinar, Dr. Venkateshan Kumar sir, who is Assistant Professor, Department of Orthopaedics, and who is going to be sharing his thoughts and his expertise with related to role of denosumab in giant cell tumor of bone. Over to Dr. Venkateshan Sampath sir.
Good afternoon, everyone. First of all, I wish to thank Professor Rajesh Malhotra sir, Dr. Bhaugak sir, Indian Fragility Fracture Network, and the Inters Pharma, and also the OrthoTV team for giving me an opportunity today. Is my slides visible?
Yes, sir.
Okay.
You can make it full screen, sir.
Yeah, I've done that.
Thank you,
okay. Sir. So, today, I'll be trying to elaborate upon the role of denosumab in giant cell tumor of the bone. So, denosumab is the only approved FDA drug for GCT of bone, and it has been in the limelight for quite some time now. It's been in the limelight for the past 1 decade, maybe 10 years. And initially there was a huge enthusiasm with denosumab, and everybody started using it. Then, as with any other therapy, there were reports of some recurrences and other problems associated with denosumab. And this has been a subject of constant debate in every musculoskeletal oncology meeting. When should I use denosumab? What is the role? How long should I use it? When should I stop it? What are the side effects? So today, I have collected the maximum evidence, and I also try to give you the basic science behind the use of denosumab in GCT of the bone. These I do not have any conflicts of interest. And to begin with, we must understand what is GCT. GCT is a neoplasm of stromal cells that have the ability to recruit white blood cells or macrophages. So, when Bloodgood coined the term giant cell tumor, he thought the giant cells are actually the neoplastic cells, but it is a misnomer. The giant cells are not the actual malignant cells. The neoplastic cells are in fact the stromal cells. So this is a histological picture of a giant cell tumor. Typically, you will see there are multinucleated giant cells which have been marked, and then you will have stromal cells which are spindle shaped. So these giant cells were initially thought to be the neoplastic cells, but now we understand the stromal cells are the neoplastic cells, and the giant cells are actually reactive. So how does it happen? The stromal cells produce rank ligand, and this rank ligand binds with a rank receptor on the macrophages, which coalesce to form the giant cells. And as we all know, these giant cells are in fact osteoclasts, and the main function of osteoclast is bone resorption. So that is why we will get a lytic lesion in a giant cell tumor, typically located in the epiphysis of the bone. Okay, but the recent understanding also says that GCTs are not heterogeneous, but there in fact is a distinct mutation. The mutation is located in the histone protein H3F3A. So that is a reason why I'm trying to talk to you about this mutation, because we will understand the role of denosumab based upon this particular targeted mutation in GCT, and a very close tumor, chondroblastoma, is known to have H3F3B mutation. Okay, how does it happen? A single nucleotide is changed from GGG to TGG, and this results in the change of an amino acid, and hence there is a specific targeted mutation resulting in the formation of stromal cells, which instead of producing bone, they start secreting rank ligand, which in turn will cause activation of the rank receptor leading to lysis. So please try to spend some time in this slide. Here you can see that there are 4 different slides. All these are GN cell tumors, but GN cell variants. The first slide, A, is a GCT of the bone, B is a chondroblastoma, C is an aneurysmal bone cyst, and D is a GN cell rich osteosarcoma. So when they tried to put the marker for H3F3A, that is H3.3G34W, only the GN cell tumor, the primary GCT, took up the stains, where all the rest of the GN cell mimicking lesions did not take up the stains. Okay, so we must understand, when this stain is taken up, it means the neoplastic cells are still present. Okay, so how does Denosumab act? It is a monoclonal antibody. So the antibody will prevent the ligand and the receptor interaction to prevent the activation of the macrophages. So we must understand, the antibody is not killing any cell, it just prevents an interaction, thereby inhibiting osteoclastic activation and decrease in bone resorption, which actually shows up as sclerosis in a GN cell tumor. So why do we need Denosumab? Because it will reduce tumor size, it will decrease the vascularity, and it will make the tumor well encapsulated. So this well encapsulation of tumor is the most important thing, because potentially a tumor which will need a resection of the joint as well as the tumor can be converted into a tumor which can be curated. But there is a downside. See, this is a GCT of sacrum, which is very, very vascular, as you can see here, multiple T2 areas on the top. After 4 doses of Denosumab, the vascularity has gone down significantly. Okay, so this is the slide which will explain all the interaction. The rank ligand is present on the stromal cells. The rank is present on the WBCs. The rank ligand interaction will lead to activation and lysis. And where does Denosumab act? The Denosumab acts here, preventing the rank and ligand and rank interaction. So Denosumab will induce tumor reduction and bone formation, and this has been well documented in the literature. But the problem is when to use it. You can use it as an adjuvant therapy. What is adjuvant therapy? You do the surgery and you can use Denosumab to reduce the recurrent risk following the surgery. So when you use something following surgery, it's adjuvant. Whereas when you start giving therapy even before surgery, it is called neoadjuvant. And neoadjuvant therapy may or may not continue after surgery. So my take home today is Denosumab is very useful in a neoadjuvant setting, but on the adjuvant setting, it has got some disadvantages, which we're going to see in the next few slides. See, this is a case of GN cell tumor of a second metacarpal. You can see it is highly lytic. It would have definitely required an excision. But on giving multiple Denosumab therapy, you can see that it has gone a very good sclerosis. The sclerosis has increased with subsequent Denosumab therapy. We have in fact curated, you can see a thick cortical shell there, and we have done a bone grafting. Okay, this is the X-ray. So the problem with Denosumab is, while it is inhibitory to the activation, it is not tumoricidal. Okay, so here we have a translational study from JBJS where they have taken specimens of patients treated with Denosumab and they have cultured the stromal cells. So what they have found that treatment with Denosumab partially addresses the GN cells by wiping out the osteoclast, but the neoclastic stromal cells still will continue to proliferate. So GCT, in a GCT, if you give Denosumab before surgery, And then if you operate upon the surgery to remove these stromal cells, then it is quite effective in the neoadjuvant setting. But there are reports, this is from JBJS, where they have said there is an increase in risk of local recurrence following curettage. Okay, so why does it happen? You can see this is a study where they have recruited 25 patients in the Denosumab arm, 222 patients in the curettage alone arm. In the curettage alone, there is only 16% recurrence, whereas in the Denosumab arm, there is a 60% recurrence. Why does it happening? So why does it happen? So again, if you remember my initial slides where we have shown you the utility of the histone markers, see, you have 3 slides here. The first slide shows the GN cell tumor untreated. Second slide shows partially treated. Third slide shows treatment fully with Denosumab. You can see on a comparative histological marker, initially only the stromal cells are taking up the marker. But later, the bones which started forming also started engulfing these tumor cells, and it is very well shown in the slide F that inside the bone which is formed after Denosumab treatment, the stromal cells are entrapped within this calcific matrix. So after stopping Denosumab therapy, if we have not done an adequate curettage, these stromal cells are going to get reactivated, and that is the cause of high recurrence. Okay. So how do we give Denosumab? We give 120 milligram once every 4 weeks, but on the initial setting, we can give additional 120 microgram. Sorry, it's not milligram, it's microgram on day 8 and day 15 only in the first month of therapy. The site of injection is either the upper arm, upper thigh, or abdomen. It is given as a subcutaneous injection, and the adverse reactions are arthralgia, headache, nausea, vomiting, hypocalcemia, and osteonecrosis of jaw. Hence, as Professor Malhotra mentioned, we need to check the calcium phosphate, alkaline phosphatase levels, and we also need to look for dental caries to rule out any infection in the teeth, which can give rise to osteonecrosis. Okay, what are the downsides? One is recurrence, as we know. Other is high cost, which over time, I hope it will come down. Next, the effect will completely vanish if stopped. So if you give somebody a Denosumab, and if you stop the therapy for 6-7 months, the tumor is going to come back in its own aggressive nature. And if you give in the adjuvant security, say for example, I have operated upon a GCT of sacrum, I have left some tumor inside. In the post-operative setting, if I start giving Denosumab, there is no consensus on how long it should be given, because the day you will stop it after a period of say 3 to 6 months, that is going to be a recurrence. So the duration of treatment, the role in inoperable tumors, and post-surgery treatment is still under research. So what can we do? So likewise we have Denosumab, we have the bisphosphonates, which act both upon the osteoclast as well as on the stromal cells. So the bisphosphonates, in contrast to Denosumab, are tumoricidal, means it can kill the cell, it can kill the germ cells also, it can kill the stromal cells also. So we all are well versed with bacteriostatic and bactericidal drugs. While static just controls the bacteria, cidal kills the bacteria. Similarly, we have zoledronic acid and Denosumab. While Denosumab is tumoristatic, the zoledronic is tumoricidal. But zoledronic is not ubiquitously useful. There are a certain percentage of tumors where zoledronic will be effective, but there are a certain percentage where zoledronic will not be effective. On the other hand, Denosumab will be effective in almost all primary GN cell tumors of the bone. So we have different tools here. So this is a paper from Cheng et al., where they have shown that bisphosphonates have induced apoptosis of stromal cells as well as GN cells. And this is again a paper, Propagation Sierra, where they have shown that it reduces the recurrence risk. And this is a head-to-head comparison of Denosumab and zoledronic. And this is a basic strain study where they have cultured the stromal cells. What they have found that zoledronic acid exhibited a dose-dependent inhibition in cell growth, in contrast to Denosumab, whereas Denosumab exerted only a minimal inhibitory effect. But out of the 3 cell lines, 2 died with zoledronic acid, but 1 cell line still was alive. So we have ourselves published our results of role of zoledronic acid in germ cell tumors, and we have shown that compared to control group, the apoptotic index is high in patients given zoledronic acid, and the VAS score for pain has diminished after giving zoledronic acid in a comparable tumor. This is the table from the paper, as you can see that in the bisphosphonate group, we have high pyknosis, high nuclear BEPs, all indicators of apoptosis. So this is one of the cases from the paper. As you can see, with further dose of zoledronic acid, the tumor has completely calcified, but this is not an universal case. Okay. So my take-home message for you today will be, primary GCTs have a genomic basis, which is H3F3A mutation. GCT in Denosumab inhibits the tumor growth, whereas bisphosphonates are tumoricidal. Tumors undergoing excision, Denosumab is definitely useful, no doubt about it. You have a big tumor in the GCT in the sacrum, and you want to excise it with reducing the blood loss and making the tumor well encapsulated. Denosumab is very useful, no doubt about it, but you have to excise the tumor completely, whether it is sacrum, whether it is a distal radius, or whether it is a proximal fibula. But in tumors undergoing curettage, there is a high recurrence risk. So in those cases, you can consider zoledronic acid. So like how Professor Malhotra sir has mentioned that in osteoporosis, that Denosumab and zoledronic have got additive effect. Similarly, our anecdotal experience says that in a patient whom you have given Denosumab, and the tumor has got well calcified, and if you had planned to do a curettage, after curettage, you can give 3 doses of zoledronic acid. So this considerably reduces the recurrence risk, but we are yet to publish this study. It is still under process. So hence I have not quoted it. I have not even written it. I'm just mentioning it. So we must all understand reducing the recurrence risk after GCT is a huge task, and there are multiple tools in the armamentarium of an oncosurgeon, including an organ laser. You can have zoledronic acid, you can have Denosumab, you can have carbolic acid, you have hydrogen peroxide, you have mechanical burr. So there are so many tools available. If you want to compare it with a real life situation, see, you have a mask which can prevent the entry of coronavirus, but you have a sanitizer which will kill the coronavirus. Both are tools, we have to use it wisely. But if you take it very lightly, we are going to get some major disasters. Like this female who have used a sanitizer on the head, and she had lighted a candle and she has got a 3rd-degree burn. So it is Denosumab is one more tool in the armamentarium, and we have to use it wisely. If you have any doubts, feel free to contact me. This is my email address, venkatortho4@gmail.com, and these are my references. Thank you very much. I am happy to take any questions at the end, and over to Dr. Bhavgar sir.
Thank you, Dr. Venkatesan sir, for enlightening us on the role of Denosumab in giant cell tumor. Moving forward, it's my pleasure to invite Dr. Bhavgar sir, who is additional professor, Department of Orthopaedics at AIIMS Hospital. He is a committed academician of national and international repute, and who has a special interest in spine as well as upper limb. I would like to invite him with these few words to deliver his talk on lesser known targets of Denosumab. Dr. Bhavgar sir, please. Bhavgar sir, can you unmute yourself, please? Yes, thank you.
Thank you, Javed. And we know that the Denosumab is basically anti-rankle antibody, and my job is basically to recapitulate what has already been said by Professor Malhotra and Venkatesh. And we know that the denosumab has come up as a mirific molecule in the treatment of osteoporosis and the giant cell tumors. The important thing is that the denosumab is quite rapidly absorbed when given subcutaneously, and we can detect it within the serum after 1 hour. And the maximum serum concentration is achieved in 5 to 21 days, and the half-life is 26 days. So these are important, but we know that the denosumab is given every 6 months for the treatment of osteoporosis, and for giant cell tumors we have the specific the regime in which we give it every week for the first 3 weeks, and then we give it monthly for 3 doses. So we have already, Dr. Malhotra has already told about the mechanism of action, so I'm not going to details. The important thing is that they inhibit the osteoclast to decrease the bone resorption and increase the bone mineral density. Uses, we have already discussed that the postmenopausal women who cannot take or did not respond to other medication treatment for osteoporosis. So it is yet to come up as the first line treatment for osteoporosis, but yes, it is evolving, and the people are and the physicians as well as the surgeons, they are gradually recognizing its importance of treating these group of patients. The men who have an increased risk of fractures, who cannot take or didn't respond to other medication treatment for osteoporosis, they are again another candidates for using this drug in osteoporosis. Glucocorticoid induced osteoporosis who have taken steroids for at least 6 months, and they are at an increased risk of fractures. And again, they are also used to treat bone loss in men who are at high risk of fractures while being treated with androgen deprivation therapy for non-metastatic prostate cancer. They have a role in this denosumab has a role in metastatic cancer as well, but this is just one of the indication for using the non-metastatic prostatic cancer. And also this denosumab is used to treat the bone loss in women with breast cancer who are receiving the adjuvant aromatase inhibitor therapy, and by nature of using this aromatase inhibitor therapy, they are at increased risk of fractures. Then they are again, the denosumab is quite useful in prevention of skeletal related events in patients with multiple myeloma and in the metastatic disease of the bone. The other use of denosumab is in the hypercalcemia of the malignancy, especially if it is refractory to the bisphosphonate treatment. So coming to the treatment-induced bone loss, this GIOP is the most common cause of secondary osteoporosis. We know there are several mechanisms by which the glucocorticoids, they affect the bone density. Name a few, like they can increase the expression of rank ligand, they can reduce the expression of the rank decoy receptors, which Dr. Malhotra pointed out, or the OPG. And these reactions, they increase also, they increase the osteoclastic bone resorption. And with long-term use, there is a reduced bone formation via increased osteoblasts and osteocyte apoptosis, and there are various other mechanisms also. And the denosumab is proven in the literature also that it is superior to bisphosphonates and its effects on the lumbar spine and the total BMD in patients with GIOP. However, there was no difference in the incidence of infection or the adverse events or the serious adverse events. So denosumab has recently been approved by the US FDA for GIOP, especially in patients with high fractures who have got multiple risk factors and who have failed or intolerant to other anti-osteoporotic treatment. The basic dictum is that if one patient is continuing or initiating more than 7.5 milligram per day prednisolone or its equivalent and is planning to use this drug for at least 6 months, these are the candidates, these are the patients who are the candidate for the denosumab treatment. Coming to the prostate cancers, the androgen deprivation therapies in the form of bilateral orchidectomy or the treatment with the GnRH agonist, they are commonly used in the standard first-line therapy for the prostate cancers, and they are also used in patients with an increasing PSA levels after primary therapy. And there are several mechanisms by which these acts I'm not going to detail, but the important thing is that these androgen deprivation therapy, it increases the bone resorption, reduces the bone mineral density. It increases the risk of fractures in men with prostate cancer, and the risk of fracture increases with the increasing duration of this therapy. So the denosumab has shown a significant increase in the BMD at all the respective sites in these patients with prostate cancers, and it is quite useful for decreasing the risk of fractures in patients with non-metastatic prostatic cancers. Coming to women with breast cancer who are receiving the tamoxifen, especially with the hormone receptor positive early stage breast cancers, they significantly reduce the tumor recurrence risk and improve the patient survival. However, these aromatase inhibitors, they can increase bone loss and they can increase the fracture risk. And this is basically mediated by the activation of the osteoclast. So denosumab, again, by virtue of its nature of inhibiting the rank ligands, it suppresses the bone resorptions. And because of its targeted specificity and its twice yearly dosing, it could be an alternative treatment to bisphosphonates for the long-term management of bone loss, especially in female with breast cancer who are receiving this aromatase inhibitor therapy. And again, there is evidence in the literature that it has shown that this can lead to the significant increase in the BMD over 2 years at trabecular as well as the cortical bone, with overall adverse events rate similar to that of the placebo. And this is again another paper in which they have compared it with the zoledronic acid, and the denosumab was found to be superior to prevent the skeletal related events in patients with breast cancer receiving the denosumab. Coming to the malignant tumors, it is very useful in patients with metastatic bone diseases or the myeloma, multiple myeloma, who experience frequently like the osteoclast mediated bone destruction, which can result in the skeletal related events, which we define as the fracture. If there is a need for additional surgery to the bone, if there is a spinal cord compression because of the posterior bulging of the vertebral body, if there is hypercalcemia, because they lead to pain and decreased quality of life. And the patients who experience this one skeletal related event, they are more likely to experience the subsequent skeletal complications. So bisphosphonates, they are commonly used for treating these or delaying or preventing these SREs. Mechanism is that these tumor cells in the bone, they lead to increased expression of rank ligands on the osteoblast and their precursors. An excessive rank ligand induced osteoclast activity, it results in resorption and local bone destruction, with evidence of which has been shown with the elevated levels of bone turnover markers leading to these events. And denosumab, again, by virtue of binding and neutralizing the rank ligand, inhibits the osteoclast function and prevents the generalized bone resorption as well as the local bone destruction. Again, the studies have proven that the denosumab is non-inferior, which is trending towards the superiority with statistical analysis to zoledronic acid in preventing or delaying the first-on study skeletal-related events in these patients. And it represents a potential novel treatment option, which is very convenient to dose as well as the once in 6 months, and there is no requirement for renal monitoring or the dose adjustment. So we know that the another indication is the hypercalcemia of malignancy. It often occurs as a complication in patients with advanced cancers, characterized by elevated serum calcium, and the symptoms, they can range from nausea, vomiting to bone pain, fatigue, and confusions. Patient may or may not respond to these IV bisphosphonate therapy. Mechanism is again either by the humoral mechanism in the form of the systematic secretion of the parathyroid hormone related peptide by the malignant cells, or it can be because of the local osteolytic bone resorption, where the tumor cells, they are secreting these activating cytokines. So the denosumab again inhibits the rank ligand, and it can causes the more rapid reversal of established hypercalcemia, and it basically more effective than the high dose bisphosphonates, and it is useful in patients also who remain significantly hypercalcemic despite the patient who have received the IV bisphosphonate treatment. And again, this is the study which has shown that the denosumab is non-inferior to zoledronic acid in preventing these skeletal related events because of this thing. The doses, again, if we are going to use it for multiple myeloma and bone metastasis from solid tumors, again we give it 120 milligrams. This is double the dose of the which we use in osteoporosis every 4 weeks. In GCT and hypercalcemia of malignancy, we use the same dose, which Dr. Venkat has pointed out, that the 120 milligram once every 4 monthly, once a week for first 3 doses, and then we gave it for monthly. And the site of injection and the route, we know, we have already discussed that subcutaneous dose is used. So the recommendations are that we have to monitor these calcium levels periodically. Again, we have to supplement it calcium and vitamin D these patients in a sufficient manner. And dental and oral examination, they are must. Specific adverse events, people have also noticed that in different indications they have a little bit different adverse effect profile. and one has to be very careful that in bone metastasis for solid tumors, the most common are the fatigue and the hypophosphatemia, while multiple myeloma, they are diarrhea, back pain, thrombocytopenia, and the hypocalcemia, and the upper respiratory tract infections. And giant cell tumor of bone, again, they are more like nausea, back pain, fatigue, and pain. And the hypercalcemia of malignancy, they can cause dyspnea and the vomiting, anemia, and constipation. The contraindications are again patients with hypercalcemia and those with a known allergy to the denosumab. So we can say that the denosumab is like a multiple projectile bullet, and we have to be very careful, judicious, and watchful in its use. And still, we must know that it is not a panacea, and it has its own set of tipping points where one can be trapped, and one has to be very cautious while using this denosumab. Thank you.
Thank you so much, sir. That was quite an interesting session, and I would like to thank all the speakers, Dr. Malhotra sir, Dr. Garg sir, and Dr. Venkatesan sir, for providing us a huge insight into the utility of denosumab in regular clinical practice. Yes, we have few of the questions from the delegates. With your permission, should we start, sir? Can we start question and answer session, sir?
Please do.
Sure, please.
Sure, sir. So the first question which has come is sometimes if the T score is very low, that means the osteoporosis is very severe. In that case, sometimes one medication might not be enough. So if we want to go for a combination therapy, can denosumab be combined with bisphosphonates, other anti-resorptives, or anabolics? So what is your take on this, sir? I think Dr. Malhotra would be the most suitable for this.
Yeah. So just 2 or 3 practical points for practice. One is anybody who comes to you with very, very low T score, make sure that you're not dealing with osteomalacia. Make sure that the vitamin D is all right, alkaline phosphatase is, and the you will realize that if the bone is not mineralized, it will give a very low value on BMD, which can just be corrected by calcium and vitamin D. So I'll give you an example that you saw that the best drugs give an increase in BMD by 8% or 9%, right? And if you give a therapy and you find 20% increase in the bone density, it's possibly the calcium and vitamin D which you gave along with the medicine which works. So rule number 1 is that rule out, and I told you that the hyperparathyroidism, primary or secondary, is common. Vitamin D deficiency is common. I can give a dozen reasons why an old osteoporotic patient will be vitamin D deficient. So first thing is make sure there's no vitamin D deficiency, there is no osteomalacia. Correct that, and you will get the correct picture of the bone mineral density. Now, presuming that the patient has very low bone mineral density, even then currently there is very little evidence or support, although there are some studies, very little support for multi-drug therapy. And I'll give you the reason why. When you combine 2 drugs, you don't only combine the cost, but you combine the side effect. And the benefit after combining 2 therapies had to be overwhelming for you to use them together. And a second and a more important reason is that, somebody who gets a menopause at 45 or 50, which is not uncommon in Indian population, has got maybe another 25 to 30 years at least. Now, as happens in rheumatoid arthritis or any other chronic disease, after a time, you keep on running out of options. For example, you give teriparatide. Can give it for 2 years, right? And then you have to stop. You give bisphosphonate. You can give it for 5 years. After that, you are worried. So then, even at 5 years, you have to weigh the risk-benefit ratio and decide whether the risk of osteoporosis fracture is more than that of possible disadvantage of having the bone suppressed for any longer. So there are studies of combination of denosumab also with teriparatide. See, the commonest combination anybody wants to try is a anabolic with anti-resorptive.
Anti-resorptive. Yeah.
That is what they want to say, that why not suppress remodeling. But I told you that, at the most, a lot of studies have shown that, say, for example, if you combine a very strong anti-resorptive with teriparatide, you may actually blunt the effect of teriparatide. That's why I wanted to tell you the mechanism of action of bisphosphonate is to suppress bone remodeling, and teriparatide is to accelerate remodeling or stimulate remodeling. So currently, I would say, even in a very severe osteoporosis, after you have ruled out osteomalacia, I think start with a single drug, because unless the patient has a very limited life expectancy and you want to give everything in 1 or 2 years, otherwise you will run out of options. You start
Yes.
two drugs together, you would have exposed patient to maximum duration for both. And you have seen something which is very prominent with denosumab, that is wearing off of the effect after discontinuation is not exactly non-existent with other therapies. With other therapies also, the effect wears off when you discontinue them, though not so remarkably or not so strikingly. So I would say that currently, unless it's a very unique situation, it's not recommended to combine therapies.
Sure, sir. So what we understand is that unless not required, we should not go for combination therapy. If needed, then the best combination would be with teriparatide.
Yes.
Yes, sir. Now, moving ahead, I think the next question is directed towards Dr. Venkatesan, sir. There is a question that okay, we now have a quite a good number of amount of data regarding use of denosumab in GCT, and the dose is also there that you start with 120 milligram weekly and then go for monthly. How long to continue, and what are the markers which should help us to understand that when we should really stop denosumab and what to do after that?
Okay. So before I answer this question, it is important to know what we want to achieve by giving denosumab. Okay. So if you are going to give denosumab to assist your surgery in a neoadjuvant setting, okay, so then you have to use 3 doses or maximum 4 doses of denosumab, and then you can go for surgery after the last dose. Okay. Supposing if you want to give it after a surgery, okay, the primary treatment for giant cell tumor is surgery. So there is no doubt about it. If you want to give it after a surgery, then we must understand the role of denosumab will stop once once we stop the drug. The tumor is going to come back after a gap, maybe in a 3 to 6 months. So there is no universal consensus for that. So I would strongly suggest use of denosumab only in a neoadjuvant setting. Means you give it before your definitive treatment, which is surgery.
Okay, fine. And when to stop, sir? Anything on that? After
That's what
that?
I'm trying to say.
Uh-huh.
If you want to give it before surgery, you will stop it. You will give 4 doses, and then you will operate upon the patient.
Okay.
That's it. You don't have to repeat it.
Great.
But if you want to give it after a surgery, say for example, you done a curettage, and then you are worried there is some residual tremors, and if you started denosumab, then the denosumab will cause calcification of the remaining tumor. But as long as you don't remove it, when you stop denosumab, the tumor will come back again.
Okay.
Okay. So there is no definitive endpoint there. So that's why I do not recommend it as an adjuvant therapy.
Great. Thank you so much for your response, sir. Next question, I think, okay, Dr. Garg, I would like you to answer this. There are multiple newer indications which you highlighted in which denosumab is finding its use. We know that when it comes to osteogenesis imperfecta, the bisphosphonates like zoledronic acid and all other therapies are regularly established therapies for the same. So in that case, can denosumab be useful, and can it replace bisphosphonates? Would it be better than those in pediatric patients?
As such, right now, I am not aware of any such study in the role of denosumab in osteogenesis imperfecta. Yes, given it's the same mechanism of action, its role can be explored. Definitely, it can be explored. But right now, I am not aware of any such study.
Sure, sir. Another thing which you presented in your presentation, it came out that yes, hypocalcemia is one of the side effects for denosumab. So and regular monitoring is required. So are there any specific timelines after giving denosumab at which we should go for denosumab for calcium levels? After a week, after 3 weeks, after a month? So anything regarding that, sir?
Normally, I am not aware that as such, if the patient is not having any problem or any complications, that regular monitoring is necessary. But yes, one should be cautious and one should be aware of the symptoms. If somebody is having tetany or this thing, then they should get checked. At the first go. Professor Malhotra, are there any guidelines regarding checking these calcium levels?
I think the more important is to make sure that there's no hypocalcemia, and I don't think it needs monitoring of calcium levels. On the other hand, something like teriparatide, which we know gives rise to hypercalcemia, it is recommended that maybe 3 months down the line you should check a level of calcium once to make sure that the patient is not getting too much of hypercalcemia. And also it is advisable not to give calcium supplements if you are giving teriparatide. But with denosumab, I am not aware of any such recommendation to monitor. The problem with bisphosphonates or denosumab is that if it's already hypocalcemia, they can aggravate the hypocalcemia, which can even cause respiratory embarrassment or need for the ventilatory assistance, which can be the one extreme case. So make sure that you're not any of these anti-resorptive treatments should not be given in the setting of osteomalacia, because they aggravate the osteomalacia. So they should always be given after correcting the calcium and vitamin D levels, and particularly vitamin D levels, because then they take care of the calcium. So that is the general principle. Don't give any anti-resorptive treatment unless the patient is vitamin D sufficient and has got normal calcium levels.
Sir. Thank you, sir. The last question, I think, when we have so many cancers in which denosumab is being used, when there are some patients who are having osteoporosis along with some atypical or different cancers, like someone is having pancreatic cancer or some other cancer. So in that case, should it be treated as a safe medication?
Yes, it is quite safe. It's quite safe.
Fine, fine. Great, sir. Okay, so I think that brings us to the end of the question and answer session, and we really assume, or it is quite sure that yes, all the delegates would be highly benefited with the insight which has been provided into denosumab by all the specialists. I would like to really thank all of you. And moving ahead, let me invite Miss Anjali Singh, who is from marketing department from ITAS, to express her vote of thanks. Over to you, Miss Anjali.
Thank you, sir. Good afternoon, respected speakers and all our delegates. I, Anjali Singh, brand manager of OliMap, on behalf of Inara Intas, a division of Terifrac and OliMap, would like to extend my vote of thanks to AIMS Delhi and Fragility Fracture Network of India for conducting this webinar. I would also like to thank all our speakers, Dr. Rajesh Malhotra sir, Dr. Venkateshan Kumar sir, Dr. Bhavuk Garg sir, for highlighting and helping us understand the role of denosumab in osteoporosis management and JCT, and majorly for answering all our Ws like what is denosumab, when to use denosumab, which type of patients should we opt for denosumab, or how to use denosumab, and how long can it be given. So thank you, sir, for having such an interactive session and for all your value additions. I would also like to thank our broadcast partners, that is OrthoTV, our medical advisor, Dr. Amit Jain, sir. And once again, thank you so much, Dr. Rajesh, sir, for giving us an opportunity for connecting for this webinar. And so looking forward to connect with you for many such webinars on the topic of denosumab or osteoporosis management. Thank you so much, sir. Thank you.
Thank
Javed,
you.
sir, yeah.
I also thank the INTAS team to coordinate this webinar, from all of us from the Indian Fragility Fracture Network, bringing out this on Ortho TV, and to make this webinar available to our many physician surgeons friends across the country. Thank you.
Thank you so much, sir. Signing out.
Thank you. Bye-bye.
Javed, sir, you're on mute.
Thank you very much.